In fact, my college is where I did my MBBS from, that is Christian Medical College, Ludhiana in Punjab. Our founder, her name was Dame Edith Brown. She was the first person to found a women's college in South Asia. And her motto was, "My work is for a king." They used to teach us in MBBS what "my work is for a king" used to mean. It is not from the Bible, it is related to biblical teaching. And it's only when I reached practice, when I became a consultant, that I understood what Madam meant, what Dame Edith Brown meant. When she said, "My work is for a king," she was basically telling us to be person-centric. If you view the person in front of you as a king, as God, as a representative of God, then automatically you will do your best. When we go to the temple, when we give an offering, at that particular point of time, we are doing our best. We are giving an offering with whatever best possible we can. That is true whether we go to the temple or the church or the mosque. We are serving a king, a higher authority, someone who is higher than us. If we were to do that in our OPD, for each and every patient who comes to us, for each and every family that comes to us, automatically we will be giving person-centric care. Once I understood this, then it became very easy for me to understand the guidelines for diabetes care and to bring concordance between those guidelines and what I was doing in practice. Earlier it used to be a real headache. I work in a place called Karnal. I was the first endocrinologist there. The second endocrinologist in my entire state came 9 years after me. There was no cardiologist, no nephrologist, no neurologist, no rheumatologist before I came. On one hand, I would go to a CME like this and I would learn about evidence-based medicine, something that we all swear by. But when I would go back home to my practice, I would see I'm not able to follow the evidence-based medicine. Sometimes whatever evidence-based medicine is telling me to do is just not available. The drug is not available. The test, the diagnosis is not available. Other times it may be available, but it is not accessible. So I can tell my patient, you go and get an angiography done, but the nearest angiography is 150 kilometers away. How do I send a patient with acute MI to a cardiologist who is 150 kilometers away? So it was not accessible. And other times it was just not affordable. So the guidelines might tell me do a serum vitamin D test, but the vitamin D test would be 1,000 Indian rupees, 4,000 Sri Lankan rupees. In that, the patient would say, I will get vitamin D for my entire family for the year. The treatment is much cheaper. So that was also a big challenge for me. Guidelines or evidence-based medicine on one hand, and what I'm doing in practice on the other. Then on a trip to Pondicherry, which is one of our most beautiful cities, and I would welcome you to visit Pondicherry next year. Dr. Nitin will invite you to Pondicherry. He is from that part of the country. I learned an English phrase. And Dr. Nupma, Dr. Vasanti, Chairperson, Madam, that phrase changed my entire life. And the phrase is logical empiricism. Logical empiricism. This was a school of thought, a school of science. Unfortunately, it died out in World War II. And once I learned this English phrase, I became relaxed. Because what was I doing in my clinic? Let us say you are working in an underserved part of Sri Lanka. Whatever you are doing in your practice may be different from what is being done in Colombo or Kelaniya. It may be. But that doesn't mean you are doing wrong. You may be doing empirical therapy, but there is a logic behind it. So it is logical empiricism. I'll take an example from my state. The guidelines tell me that a patient with gestational diabetes mellitus, I should try to take her up till 39 weeks of gestation. Theoretically, that is fine. But I also have to follow up the patient every week. The gynecologist has to follow her every week. The person who wrote the guidelines sitting in America has not come to my state, Haryana. They have not seen the roads of my state. They have not seen the buses of Haryana roadways. If I were to tell an antenatal lady from 34 weeks onward, you come every week to consult us, but we will not deliver you, we will not admit you, she is going to deliver in the Haryana roadways bus. That is what is going to happen. So logical empiricism for me means that if she comes at 37 weeks or so, I tell her, okay, now you stay in Karnal, get admitted and go back with a healthy baby after 2 days. We will induce. The person who wrote the guideline is fine from his point of view, evidence-based. But I am correct from my point of view, which is logical empiricism-based. Now, with this introduction, our talk becomes very easy to understand now. So there are lots and lots of guidelines. Chairperson Madam was kind and she said that I've written many guidelines. Actually, everybody enjoys writing guidelines. I think sometimes the only people who follow the guidelines are the authors themselves. And even they add a caveat that logical empiricism means every time I will not be able to follow. But our guidelines have evolved. Just like Professor Nitin said, from absolute BMI-based guidelines, we have now moved to complication-based or comprehensive therapy in obesity. Same is true in diabetes as well. And to understand the guidelines, all you have to understand is person-centric care. Keep the person in front of you. When we were students, we used to learn about signs and symptoms and signs. Now, in an advanced healthcare setup, like in Colombo city, for example, there will be very few patients coming with signs. They will come with symptoms or with complaints. In fact, as you become more and more evolved, patients don't even come with symptoms. They are asymptomatic when they come to you. That will not be true for every district of Sri Lanka. In some places, you will have patients with lots of symptoms, complications. But as you evolve, more and more asymptomatic patients will come. So therefore, now we speak of complaints and concerns. The patient may have a complaint. My glucose levels are not coming down. That is a complaint. The patient may have a concern. Madam, I got my test done. The ESR is 29. I am concerned about an ESR of 29. If that is the concern, you have to manage that. Whatever the treatment is, that is a separate matter. I am still struggling to find the treatment for ESR 29. 25 years in medical practice, I have not found the answer. But so now we speak of complaints and concerns. If you can understand that the patient's complaints and concerns are at the center stage of whatever you are discussing, then you are through. As a doctor, you are a successful doctor. When people write guidelines, they think about efficacy of drugs. They also do think about patient acceptability and side effect. And as an afterthought, they mention the cost. But when we are in practice, then this is what we think about. First of all, whatever I am prescribing, maybe dapagliflozin, empagliflozin, is that appropriate for my patient? If it is appropriate, I will begin speaking. I will begin the conversation. Like Dr. Nitin said, first you ask, and then towards the end you agree. So we'll begin the asking, the discussion. Will the patient accept it? If the patient accepts, let us say I say 4 doses of insulin a day, will you accept? Patient says yes. Okay, now can you afford it or not? That is the next step. And accuracy is important in practice, but that comes at number 4. So appropriateness, acceptance, affordability, accuracy, all going together, but accuracy is just one out of these 4 pillars. Another thing to understand, we spoke of complaints and concerns, is why the patient is coming to you. So some people, depends upon where you are, some people will come and say, Madam, I am sick, please treat me. I have to go to the bathroom 6 times a day and 12 times at night. Please fix my diabetes so that I have to go less often to the bathroom. Another person will say, my hands are numb, my feet burn, so please help me with that. So that is symptomatic relief. If you keep on working in a particular area, like you work in Colombo, you will find that these symptoms will gradually become lesser and lesser in your OPD. And then you will have more patients coming and speaking about glucometabolic health. Glucometabolic health means your patient will come and fight you. Sir, I have been paying you 1,000 Sri Lankan rupees every month for the past 10 years. Why is my HbA1c 7.1? I want that to come down. So they are worried about the number. That is a higher level of evolution. Beyond that would be, sir, please give me a medicine which will take care of my kidneys. Or madam, please give me a treatment which will prevent my kidneys from becoming spoiled. Or they might come and say, I went to the cardiologist, madam. She gave me lots of medicines. After that, my kidneys have spoiled. Now my creatinine is 1.8. So madam, can you bring it back to normal, please? So that is another higher level of evolution. In my OPD, sometimes I get irritated at, some patients, they ask lots of questions and they are very fussy. And then we will talk about kidney health, and then they will come up, they will be taking Ayurvedic treatment for 20 years. That whole time they never bothered about the kidneys. When I prescribe empagliflozin, then they will say, sir, is this safe for my kidneys? I'll say, yes. And then the question is it safe for both the left kidney and the right kidney? That also they will ask. So I used to get irritated. Actually, still I get irritated. But what you should do, you should stop that irritation and frustration right here. Do not verbalize that. You turn it 180-degree around. And then you use these patients as ambassadors or as evangelists of your practice, of good healthcare. So who is an evangelist? An evangelist is a person who spreads the good word. The good word can be anything. Here, the good word is good health. It's ABCD, all about care in diabetes. That is the good word. So I'll tell the lady, madam, you are so much concerned about your health. Thank you. I wish all my patients were like you, though actually I don't feel that. I wish all my patients were like you. And madam, you are taking care of your kidneys, your husband's kidneys. This drug is wonderful, but I would request you to do something else. In Buddhism, there is this concept of transfer of merit. So if you do good merit, you can transfer it to other people. If other people do good merit, they can transfer it to you. Let us spread good merit. Madam, next time when you go to your Rotary Club, or when you go to the temple, or you go to the mosque, you tell everybody about good kidney health. You tell them that they should not smoke. You tell them that they should get good medicine for their blood pressure. And you also tell them that now in diabetes, we have drugs which can control your glucose and improve your heart health and improve your kidney health. So madam, you must do that. You will earn a lot of merit if you do this. And then these ladies, so it is not always ladies, sometimes it is men also. Apologies to all the ladies in the house. They love talking, and suddenly she goes back empowered because see, she has to go back to her kitty party, or she has to go to the temple, or to her neighborhood gossip session, and she has learned 3 new things that she can tell. So she will say, Arre, you are taking medicine for diabetes, you should go to my doctor. He gives medicine for diabetes and kidney together in the same line. So that is how things work. So this hierarchy, just keep on developing, and you will find that your practice will develop also. Now, all these you don't learn from the guidelines, you learn the hard way. So all the mistakes that I have made over the past 25 years, those are hidden under the carpet. But you learn from patients. The single thing I would like to say is that if you actually understand the definition of person-centric care, and then if you agree with what Dame Edith Brown taught us, my work is for a king, my work is for a queen, then you're on the right track, then things move, then there is no difficulty at all. And especially for the younger boys and girls in the house, this is the way to develop a sustainable practice. Now, speaking of guidelines, earlier the guidelines were very simple. When I was a student, we had only 2 types of drugs, metformin, fenformin as sensitizers, and chlorpropamide and glibenclamide as secretagogues. Tolbutamide also we had in India. I'm told that it is still available in Sri Lanka, that we don't have anymore in our country. Though our teachers used to write a lot, and it is a wonderful drug, even if the guidelines don't mention it. So earlier the number of drugs was less, and the guidelines were also very simple. They would divide patients into obese and non-obese. So obese you give metformin, non-obese you give glibenclamide or glimepiride, whatever is available. But things have moved a long way, and now we speak of complications. So when you see this American guideline, suddenly it looks so complicated and dangerous. But it is actually quite goal-oriented. It is not so difficult. We will come to the best guideline of all in a few slides from now. The Americans say almost the same thing, the American physicians say almost the same thing that the American endocrinologists say. But the American endocrinologists do tell you that depending upon the height of the peak that you have to climb, you change your strategy, you change your approach. So if you have a person with HbA1c less than 7.5, you will begin with 1 drug. If the A1c is more than 7.5, you can begin with 2 drugs. And if it is more than 9 or 8.5, you can begin with 3 drugs. So you can start a triple oral therapy. You don't have to wait for failure. So be more aggressive. It's like, let's say a snake comes in front of you. So what will you do? Either you get bitten by the snake or you hit it. And if you have to hit it, you will get only one chance. So you might as well hit it with the best stick that you have and with the maximum energy that you can bring. So hit early, hit hard, and if the A1C is high, hit with multiple drugs. Exactly same thing we get from the UK as well. Many of our experts here are trained in the UK, and you realize that United Kingdom guidelines are a very pragmatic balance between evidence and also public health concerns. So they look at cost, they look at economy as well. And here what the guidelines tell us is almost similar to what the Sri Lankan guidelines tell us. So let us look at our guidelines, Sri Lankan guidelines. So what they say is, in very simple words, you have everybody with type 2 diabetes. You divide them into two groups. One is people who have heart disease or are at high risk of heart disease. The other is those who are not at high risk of heart disease. Now, this is not simplistic, this is actually correct. The only catch is that everybody in South Asia is at high risk of heart disease. Now, let me talk from an endocrine perspective. When you have persons with hypothyroidism, we will classify them into three. One is overt hypothyroid. Overt hypothyroid, T3, T4 are low, TSH is high. Everybody will treat, so not difficult. Some people will come and show you tests which are euthyroid. T3 normal, T4 normal, TSH normal. Again, no brainer, we will not treat. In between, you have subclinical hypothyroidism. Some of them we will treat, some we will not treat. Some the nephrologist will treat because she knows that when you give thyroxine, the quality of life will improve. The quality of life will improve because the iron uptake will improve. Otherwise, the CKD patient has got functional iron deficiency. And you can keep on giving as much iron as you want, the HB will not rise. Quality of life will go down. But you give a slight amount of thyroxine, maybe 25 microgram, and you will see that the hemoglobin will rise to 10.5. Quality of life will go up. But here you need her help, you need the nephrologist's help. The cardiologist will prescribe. She is struggling with heart failure. The patient's symptoms are not improving. You give iron, you give thyroxine, and suddenly you see that the heart failure improves. So when they speak of the pillars of heart failure management, they assume that the foundation is strong. The foundation is good glucose, good thyroid, good testosterone, good hemoglobin. This is easy. Now come to ASCVD, atherosclerotic cardiovascular disease, our topic. So you have people with diabetes. Some have got overt ASCVD. That is easy. They give you a history of stroke or MI. So obviously you will treat them as high-risk patients. There are those who have got subclinical ASCVD. No clinical features, but when you do imaging, when you do biochemistry, you find that they are at high risk. They may have microalbuminuria, high hsCRP, high NT-proBNP, bad lipid profile. But how many tests will you do in how many patients? The NT-proBNP should be done for risk stratification, but it is expensive. Microalbuminuria is also not cheap. So you have overt ASCVD, that was easy to diagnose. You have subclinical ASCVD. We are able to diagnose quite a few, but I am sure we miss many, many more because we don't do the tests. Now it becomes more complicated. Then you have patients with atypical ASCVD. Atypical ASCVD is patients who come with anginal equivalents. Somebody coming with palpitation or arrhythmia. Somebody coming with breathlessness, dryness of mouth on exercise, clamminess of the skin on exercise. Someone with someone with dysfunction of other vascular beds, maybe femoral vascular bed. So the patient comes with claudication pain, pudendal vascular bed, erectile dysfunction. Dizziness, is the dizziness functional? Is it because of transient ischemic attack? We do not know. So atypical ASCVD is a huge, huge burden in the country. The problem with atypical ASCVD is patient comes with same symptoms. Actually, the patient should be going to the cardiologist, but I will diagnose as hot flash. The physician will diagnose as maybe hypokalemia. A general practitioner will diagnose as heat exhaustion. Maybe the pharmacologist will think of something novel. You must have taken 2 drugs together, so there is a drug-drug interaction. That is what is causing your problem. And the vast majority of us will say, acute panic attack, anxiety, you sit at home, take an alprazolam, while actually we should be sending the patient for cardiac evaluation. So this, first of all, was subclinical ASCVD. We cannot pick up. We can pick up, but it is difficult. Atypical ASCVD, we can pick up, but again, very, very difficult. And how many patients do we have in Sri Lanka or India where we are absolutely sure that they do not have ASCVD? Hardly any, because the guidelines tell us not to do a resting ECG. They tell us not to do echo. How many angios can we get done? You can't do an angiography of the entire country. Even if you do, will you do a carotid angiography or a coronary angiography or a renal one? Which one will you do? So therefore, how many patients are there in the OPD where we can be absolutely sure that there is no ASCVD? Very few. So the vast majority of our patients will have subclinical ASCVD, that is 50% actually, or atypical ASCVD. Therefore, keeping this in mind, it would make sense to treat all Indian, all Sri Lankan people living with diabetes as being at high risk for ASCVD. That is the take home. Because we cannot do all these things in the OPD. If you want to get a quantified risk factor, a risk score, then it is a good idea to check something called Q risk. And you can do that right now on your phones. So you just type in capital Q for Queen, Q risk 3. This is a British website. They will take you there. You put in your own data. You don't need to know a single number, your cholesterol or anything, even that. And you can put in Indian or other Asian, whatever ethnicity you want, Indian or other Asian, and you will get a risk factor, risk score. So your patient will, let us say the risk score is, in the next 10 years, there is a 19.2% chance of developing a vascular event. Now that is high. So you tell your patient, now do you want that 19% chance or do you want to bring it down? So patients will say, yes, I still have to get my children married. And I want to go to Australia also, I want to see the world. So how can I don't want to die. I don't want a heart attack. So then, sir, let's begin now. Begin exercising, stop smoking, take aspirin, take statin, whatever is required, and take SGLT2 inhibitors. So this is how you can motivate your patient to take therapy. Coming back to diabetes care and coming back to our guidelines. So when you look at the Sri Lankan guidelines, what they tell you is that if your patient is at high risk of ASCVD, and we have seen that almost everybody in the country is at high risk, we should add SGLT2 inhibitor to metformin. Whether your patient has got good glucose control or not, we should add SGLT2 inhibitor. And why so? Because there is data to show that this will improve glucose control, it will reduce the risk of cardiac events, it will reduce the risk of renal events, it will reduce the risk of hospitalization for heart failure, and it will reduce the risk of premature death. So when we explain to our patients in this manner, and we get hold of those, glycemic evangelists or ambassadors in our OPD, then once you do that for a month or two in your practice, you will find that your patients themselves will come, let us say it is a young man in practice. So, and you told one of your patients, we have medicines which improve your glucose and prevent death and protect both your kidneys at the same time. You will find that her sister-in-law, they will come to you and they'll say, doctor, you give me that medicine which you gave to my sister or sister-in-law. So initially a month or two it may take to motivate your community. Then your community themselves come and ask for the treatment. And life becomes so easy. At the same time, let us add a word of caution. SGLT2 inhibitors should be prescribed to everyone with diabetes, with type 2 diabetes, provided that they are not contraindicated and provided that they are well tolerated. So we should be aware of the contraindications of SGLT2 inhibitors. For example, past history of upper UTI, like pyelonephritis, recurrent or refractory genital tract infection, recurrent or refractory urinary tract infection. These are contraindications. How do I work in my OPD? In some patients, we are able to get all the tests done. In many, we are not able to. So I also work in a relatively underserved part of my country. But what we have done a triage and we have tried to classify all patients into 3. So some of our patients are anabolic, like my build, but this is not a happy anabolic, it is a maladaptive anabolic build. All these patients must be given SGLT2 inhibitors. Other patients will be catabolic, extreme catabolism, lean, thin, marasmic. Usually they have type 1 diabetes or pancreatic diabetes, which is common in my part of the subcontinent, or they will have burnt out type 2 diabetes. In these patients, if you are using SGLT2 inhibitor, use with caution. Make sure that you do the test. Make sure you calculate the EGFR at least. So we will request our colleagues from cardiology, nephrology to talk about the caveats, the EGFR. Should we do, should we not do? How should we do in the Sri Lankan context? Make sure there is no acute kidney injury. Make sure there is no acute heart failure, which is actually requiring admission. Send for admission first. So be careful in these catabolic patients. And in the eubolic patients, that is in the middle, of course, the dysmetabolism is in terms of glucose metabolism. But if everything else is fine, again, SGLT2 inhibitor should be provided. So you do a triage. You divide your patients into 3. The maladaptive anabolic patients must get SGLT2 inhibitor. Eubolic, ideally they must get, and catabolic, think twice or at least get the investigations done before prescribing. Now this was about guidelines, but my topic today has been guidelines vis-a-vis person-centered care. So the next few slides allow me to speak about what I do in my practice, person-centered care. We assess the glycemic personality of every patient who comes to us. The glycemic personality means what is the severity and style of hyperglycemia. Does the patient have fasting hyperglycemia, postprandial, both of the above, severe, mild? We also look at the urgency and utility of control. If the patient has got, let us say, CA gallbladder with diffuse metastasis, there is not much utility of control. Patient needs to go for surgery, she needs to get her cataract operated, or she needs to go for a knee transplant, or she has pyelonephritis. Then there is a high urgency, we have to control fast. These are action-oriented points: severity and style of hyperglycemia, urgency and utility of control. But 2 caution-related points: what is the risk of hypoglycemia? What is the enthusiasm and education level of the patient? So these will, maybe they will drag you back. It's better to drive slowly, but drive safe. Finally, you will reach your destination. So this sure short way, SURE, sure short way, helps us define the glycemic personality. Based upon your patient's personality, you will decide your approach, how aggressive you want to be. Your glycemic personality will also help you understand which drug to prefer. So if the patient is very symptomatic, the patient has severe hyperglycemia, insulin or sulfonylureas, glyclazide would be a good choice. If the patient wants an U for umbrella of protection, and your conversation began around, yes, madam, we have a drug which will control glucose and will protect both your kidneys and the heart, then SGLT2 inhibitors are first. If you want to avoid hypoglycemia, the safest would be SGLT2 inhibitors and DPP4 inhibitors. And of course, if your patient has excessive weight, first line would be GLP-1RA, but they are very expensive. Second line would be SGLT2 inhibitors. So depending upon the glycemic personality, you choose the drugs along with metformin. Another concept that I use in my OPD is the checklist. So when we are conversing with the patient, we greet the patient, we welcome warmly, and we have to identify the cardinal issue or the chief complaint. The chief complaint is decided by the patient, not by us. So the patient may say, my chief concern is pain in the abdomen. Then you have to fix that. You can give whatever guideline-based therapy you want, but until you fix the pain abdomen, you are not a good doctor. Patient's chief complaint might be, madam, I have come to you for admission, but I have to go back after 24 hours because otherwise my employer will kick me out. Then you give intramuscular insulin, you give IV diuretic, you do whatever you want, but patient has to be out after 24 hours. And then you can tell the patient, even if you didn't do a complete job, you know, we have done this much work, this is left, why don't you come over the weekend and I will get the other test done, or I will get the other therapy done. You might be wanting to start SGLT2 inhibitor and beta blocker and ACE inhibitor together, but you cannot do that in 24 hours. So then you will say, we'll follow a sequential approach. Let me start dapagliflozin today, but I still want to add 2 more drugs for your safety. We will do that next week. You come back, get some tests done, and then we will prescribe. So the cardinal issue is decided by the patient. Focus on that. Once you have taken care of that, then the next step is, now let us take care of your CV risk. We will give you a drug, or we have already added a drug which will protect your heart and kidney. If the patient is obese, we also want to give you a drug which will optimize your body weight. And of course, all your concerns and caveats we have taken into account. So different ways of understanding the same thing, but we have put the message across. Now, many of you will say, but patients come to us from other doctors. So what do we do? So be aware of that. Look at the previous prescription. Let us say the prescription is not up to the mark. Ask the patient. Find out, do a 360-degree analysis. Did the doctor prescribe a 90 rupees tablet and maybe you couldn't afford it or you didn't want to take it? Or maybe it was not available. And the patient will say, yes, the doctor had told me, but at that time I could not afford. Then you say, madam, but now we have a newer molecule. It is even cheaper than what is available in India. So let me give you the same benefit at a lower cost. So be aware of that. All the time, patients will not tell you the truth, but you can explore, you can find out why things were so. Do not criticize the previous doctor if he is giving very high dose of sulfonylurea. The doctor would have spoken about insulin, patient would not have agreed. So use that also to your benefit. Do not criticize the doctor. You just say, see, that doctor tried so hard. He should not have gone beyond maybe 60 milligram BD. He has prescribed 120 BD. He has tried his best. Now it has not worked, so let us climb a different coconut tree. We will get to the coconut. We will get the good control. Or palm tree, whatever. Depends where you are in the country. And if you are able to do that, so first of all, build bonding with the patient. Make sure that the patient understands what you are doing, why you are doing. Offer what we call psychological first aid. We have spoken about that at CCB. Psychological first aid means you establish a compassionate presence besides the patient, not opposing or opposite the patient. So once you have established that presence, you and your patient have bonded as a team. Fix the acute concerns. Once you have proven to the patient that you are a good doctor, yes, I can correct your polyuria, I can correct your symptoms, your painful neuropathy. Then you say, okay, now let me add something else which will protect you for the next 10 to 20 years. And that is that umbrella of protection that we give with the newer drugs like SGLT2 inhibitors. And all this is done through collaboration. So that would be my take home. Let us collaborate with our patients, with our community for secure glucose control, for sufficient and safe glucose control in a sustainable manner. So the key would be collaboration, and the aim would be sustainable control for our countrymen and women. Thank you.
VIS, affordability with quality for diabetes management.